we're going to talk a little bit about the whole problem period business as well as premenstrual symptomatology. Some of what we're going to talk about you may not have heard before. A lot of times either the doctors, nurse practitioners, PAs, other healthcare providers simply don't have time, or in fact, a lot of them don't know, or they've been trained differently and don't have experience. But regardless, you're going to wind up hearing some things in this video you probably haven't heard before. If you have questions, then you just call us, or you can go watch some of our other videos. It might help explain some things. Most of the women we see are in that 35 to 50-year-old age range. A lot of this would apply earlier or later, but regardless, what we're concerned with is the problem periods and the premenstrual type of symptomatology. All of that, 100%, relates to the lining of the uterus. The lining of the uterus is the interior portion. Think of the uterus as about the size of a lemon, large lemon, small orange. It has an internal space that is lined by some hormonally active, you could think, skin. The superficial layer of the endometrium is what builds up and sheds and builds up and sheds. As it degrades and gets ready to shed, it releases a neuropeptide toxin into the bloodstream, and that is what causes all the famous symptoms: the headache, the mood, the bloating, the fatigue, the acne, the diarrhea, and so forth. Washes out, I feel better, a good week, and then of course the whole thing starts over the next month. So if a woman doesn't have an endometrial ablation, she's not going to have any of it. So I wanted to tell you what we do when people come in to see us. We try to define exactly what the problem is, and it's sometimes surprising to them the degree to which they do have symptomatology once they put it in black and white. So we fill out something we call the purple sheet for obvious reasons, and we go through how long the periods last, 5 days, 7 days, whatever the case may be, and how many of those would be heavy, flooding clots, and whether they have any irregular bleeding, and then also whether they're having any other symptoms, hot flashes that might be associated with hormonal changes. And then we go through the premenstrual symptomatology. So a lot of women don't like the periods, but then they say, yeah, but in addition, leading up to the period and first part of the period, I will have, and then what we'll do, the fluid retention, bloating. Okay, so my clothes are tight, my stomach is sticking out. I mean, what's going on with all this? So we will have people grade themselves. Yeah, that bloating thing lasts for 3 days, 5 days, 10 days, whatever the case may be. On the worst day, how does it bother you? 1 to 10, hardly any, drives me crazy. Then we ask them about their mood. The mood issues around the time leading up to the period, first part, fall into 6 categories, and we tell them what the 6 words are and say, okay, based on these words, 1 word, all the words, none of the words, some other word, how do you characterize your mood in that same time frame? Anxiety, irritable, anger, depressed, emotional, agitated. Women will choose either all of them. I'd say half of women say, yeah, all of these things. Sometimes it's just anxiety, irritability. A smaller percentage will focus on the word anger, where they're just yelling at the kids or whatever the case may be, getting in arguments with spouses, etc. Unnecessarily. I would not have this argument if the same thing happened next week, for example. And then there's the smallest group is depression, but the depression can be pretty profound, and we've seen very, very profound depression, but people say yes, but it's only in that premenstrual time frame. Then there is headaches. A lot of women will have headaches at this time frame. I would say in our experience, as we've collected data, at least 70% of women will say, yes, I have a headache at this time. This is my period headache. I will not have this headache next week. These headaches frequently are migraines. Yes, this is my period-related migraine. Light bothers me, nausea. They'll go to a neurologist. Neurologist will say, yeah, this is like a hormone caused by hormone imbalance, and then they'll give them Imitrex, Maxalt, various other anti-headache medicines, and which are a Band-Aid for the solution, a Band-Aid, not a true solution. Pelvic back leg pain, tired, fatigue over and above the usual. Food cravings. The food cravings, chocolate, salt, sugar, pretty much covers it. Some people will say meat. Some people will say carbs in general. Then there's diarrhea. A lot of people will say, yeah, but it's pretty bad. Some people will say, well, yeah, but I'm constipated. Otherwise, it doesn't bother me that much. There's a subset, I would say 10% will say, this is crippling. It's a real problem. I better not be on vacation that week. It's a big problem. Then there's acne, breast tenderness, and then sometimes there are idiosyncrasies. I won't go into all the various idiosyncrasies, but whatever it is that happens before the period or first part and goes away after the period is over all of it relates to the endometrium. So the endometrium is that inner lining. So that's the part that builds up and sheds, the bleeding. And that's the part that creates all the other symptomatology that women have. So we go through the purple sheet and then try to characterize these various things. And if a woman doesn't have an endometrium, she's not going to have any of these problems. And that's what endometrial ablation is all about. A lot of times, women will go to their doctors, and given a relatively short time with a healthcare provider or whoever it is, and she will complain about the periods. And they won't even ask her about the premenstrual symptoms, or maybe they will, but usually not. And if she says, yeah, like the periods are a problem, what can we be done about it? Almost invariably, she'll say, well, we can give you birth control pills. So this hypothetical woman might say, yeah, but birth control pills, my husband's had a vasectomy. Why am I doing this? And I don't really want to do that. What else do you have for me? Well, we could give you the IUD. She says, yeah, but I don't want to do an IUD for a variety of reasons. And then usually the conversation stops there unless she pushes and says, well, we could always do a hysterectomy. And she said, yeah, but it seems like overly invasive. If she does have the birth control pills, I can guarantee you it doesn't help anything. It may make the periods more regular, and in some cases, it may make the flow a little bit less. It is not going to change the premenstrual symptomatology, because all it is doing is putting someone through the same paces of build up and shed. I've never seen anybody, it really helps the PMS symptomatology. If she has an IUD put in, an IUD is a small piece of plastic that is inserted into the uterine space, and it emits a few molecules of progesterone every day. Every minute, if you care to think of it that way. And that progesterone component degrades the endometrium. So if you ask a woman who has an IUD in, how do you like the IUD? Usually they'll say, yeah, it's good. It stopped my period, or mostly. But it gives you a chronic, low-grade version of the premenstrual complaints. And about 80, maybe 90% of women will have a funny look on their face and say, that's exactly what I'm feeling. That's how it works. It's degrading the endometrium, causing the chronic, low-grade premenstrual symptom, whatever it is, whether it's mood, whether it's headaches. Yeah, I get a headache more frequently here with the IUD, and it's sporadic. So anyway, that's if a woman has completed childbearing, the answer may be to simply remove the endometrium. And that's what endometrial ablation is. Ablation means get rid of. So remove the endometrium. So if a woman doesn't have an endometrium, she's not going to have any bleeding. If she doesn't have an endometrium, there's nothing to degrade and release the neuropeptide, so she is not going to have all of these things, premenstrual. So there's this thing a lot of women say, you hear it all the time, I've got one good week a month. You hear this expression, yeah, after the period, I feel better. I do not have certain complaints around here. I have a better frame of mind. So after we do endometrial ablation, it's the good week, 365 days a year. And that's the reason that when women have endometrial ablation, or you read reviews online or go to our website or various other places you can read reviews, people will say, yeah, this changed my life. this was the best thing in the history of the universe. This was like a miracle. And some of that sounds like too much, like changed your life. I mean, come on. And then you look at the type of complaints she's been having, and most women would say, yeah, okay, I get it. If I didn't have to fool with all of this, sure, you could call it change my life. So endometrial ablation for a woman who's completed childbearing is frequently the answer to so many of the problems that she is dealing with. A couple of things that I think always should be done if she has endometrial ablation. First, childbearing always has to be complete. You can't have endometrial ablation done if you still are expecting to maybe get pregnant someday. Two, it needs to be done under general anesthesia. If a doctor says we can do it in the office under local anesthesia or give you an aspirin tablet or something, I would run the other way. Sometimes that would be sufficient, most of the time not. And so many women I've talked to would say, yeah, it was horrible, never do that again. So general anesthesia, we do our procedures at a surgery center, our own ambulatory surgery center. We have an anesthesiologist. I would say the other thing, it needs to be done by an experienced provider. A lot of women will hear from their doctor, well, I talked to my doctor and my doctor said, really, I don't think it really works. They always work. In our practice, in women with more or less normal anatomy, such as this, 85 to 90% will never have another period at all, ever. A handful, maybe 10 or 15% will say, well, it's great, and I love it, thank you very much, but I still have a day of spotting a few times a year. So using baseball imagery, it's always and usually a home run, but maybe a triple, but never a double, a single, and certainly not a strikeout. So if a doctor says, yeah, sometimes they don't work, the doctor doesn't have any experience, doesn't know what they're talking about, it always works. We've done 6,000 procedures. Read the reviews. I mean, they always work. It just is a question of experience of the doctor. If a woman says, I just don't, what are my other options? So let me just talk to you about that. So let's, for a variety of reasons, she says, look, I can't do this right now, or maybe I don't have insurance, or I don't have the money to get something done, or maybe I'm just conflicted. They're really, if a woman is having problems with her periods, and these periods are driving me crazy, there are really 4 things that I tell women they can have done. One, they don't have to do anything. I mean, there's not a law that says you have to have anything done. At the other extreme, they can simply have a hysterectomy. I'll cover that in a subsequent video, what a hysterectomy is and how they work and pros and cons of that. But it's pretty major surgery. It's involves being out of work for 4 to 6 weeks. Involves removal of the entire uterus, with or without the ovaries, but frequently just the uterus. And so the 2 extremes, do nothing, deal with it, and hysterectomy. The 2 intermediate options would be some form of medical treatment, and the medical treatment to control periods would be usually continuous dose birth control pills or possibly the Depo-Provera. These things work. They can be effective depending on the person. A lot of times those things will cause some degree of chronic low-grade premenstrual complaints, just like the IUD, for the same reason. If a woman is taking the Depo-Provera, it's degrading the endometrium. That is how it works. And that neuropeptide gets back into the bloodstream and causes the chronic low-grade premenstrual symptoms. That's the reason some women on the Depo-Provera say, well, I liked it okay, I didn't like the way it made me feel, and I gained weight. Well, the reason it makes them gain weight is because they tend to be hungrier, because it's causing the chronic low-grade desire for sugar, carbs, etc. So the other alternative, so there's the do nothing, hysterectomy, medical, or a woman can have some minimally invasive procedures. So the minimally invasive procedure would be endometrial ablation. Just remove this small endometrium. The endometrium by volume is a thimbleful, so not very much. which is a little bit surprising to some people. But a grain of sand in your eye is a small thing. Pebble in your shoe is a small thing. So here's a small endometrial amount of tissue, but a small thing can drive you crazy. So we remove that small thing, that thimbleful amount of endometrium, and all of a sudden never have another period, and they don't have the premenstrual symptomatology. What I would say is if you're considering, if childbearing is complete and you would like to be done with your periods and all the premenstrual symptomatology, especially if you have the migraine headaches and I'm going to a neurologist and having the mood thing that seems to be really a problem for me, and I'm yelling at the kids when normally they're just being kids, and I can deal with them a lot better on the week after my period. If you're having those types of complaints, I would definitely consider endometrial ablation. If you would like to consult with us, we do see people from all over Georgia, but we have, at this point now, are seeing people from all over the country, California, Arizona, New Hampshire, Virginia. This is just in the last month. We've done procedures on people who have come to see us. Do they not have doctors in those states? Yes, but a lot of times they're looking for a doctor who does a lot of this, who understands what the problem is, and will do it right the first time. So if you would like to talk to us, I would recommend go to our website, drashford.com, or you could call 706-353-2550. And also you could find these videos on YouTube. You could find more videos like this on TikTok. So we're trying to get the information out there and get women the answers that they need and the help they deserve.